We've got a few obstetricians on here, which is amazing because I'd really like your interpretation of this one. Something that looks a little bit bizarre, and something that's not really common, but here we go. So this lady is a Gravidas 6, para 3, that I should say, apologies. She's had 3 previous SVDs in the year 2000, 2002, and 2007, which were uncomplicated. Nope, should say para 4, my bad. She then had 1 preterm emergency cesarean section at 24 weeks in 2008 for PPROM and an arm presentation. She also had a miscarriage in 2016. In terms of her medical history, she has arthritis and psoriasis, and she's a current smoker, BMI of 27. Her latest ultrasound scan was performed at 37+5, cephalic presentation, placenta anterior high with normal fetal growth, Lycor and Dopplers. And I believe this baby was in the general average centile as well. At 26+5 weeks, she was diagnosed with GDM, which was diet controlled at the time. She had some smoking cessation input, which I do think was helping, but she hadn't completely given up during her pregnancy. She had dolteparin due to the 3 risk factors of being a smoker, her age, she was over 35, and her parity of being a para 4. And as per her own request, she was booked for an elective cesarean section at 39 weeks. 30+4, her diabetes wasn't as well controlled as we'd have liked it to be, so she was started on metformin. At 32+4, she was seen in triage for abdominal pain, although couldn't wait for a doctor's review and therefore didn't have a speculum examination, but her CTG at the time was normal. I've got it on the next slide. 36 weeks, she had a telephone appointment. She was found to be contracting 3 to 4 in 10, and that's what she was reporting. And it was advised that she went to triage, however, she did not attend. And then at 36+5, she was seen in triage for abdominal pain, which she reported as being constant as opposed to sort of contractions. Her investigations at that time were completely normal, and she was sent home. This was her.
How old is she? Sorry to be a pain.
That's it, go on.
How old is she?
She's over 35.
Yeah, okay, fine, thank you.
So this was her CTG at 32+4 for abdominal pain. Obviously, as you can see, the criteria met at 10 minutes. This is something that I sort of say to everybody in my CTG study days and whatnot. Obviously, when the criteria meets, there's no contraindication to take it off. However, for me personally, and I don't know if anyone else would agree, I'd appreciate a bit more CTG before I can sort of say, yes, I'm happy with this baby's well-being. Also, her pulse, I think at this point when she was in triage was actually less than 100. So looking at that, I would keep it on for longer, considering the loss of contact we've got there has got a fetal heart rate that looks around 105. Personally, she's reporting lots of fetal movement.
Cara?
Yeah.
Yeah, so my opinion here, Cara, is one of 2 things. Either we employ the dose regimen and we follow the dose regimen, or we don't. The problem of doing a dual approach, that after prolonged period on the dose regimen, it will not meet again.
Yeah.
So I mean, you cannot adopt both sides of the story. If you are doing a dose regimen, fine. If she's contracting, if you are suspecting you don't want the dose regimen, again, do prolonged CTG as you want. But being in the middle will not help.
So you think?
So you're happy with the CTG, Mr. Naguib?
So I, to be honest with you, Maya, I am driving because I'm doing night today, so I can't see it. But I'm just saying about the comment of the dose regimen and having a more CTG. 1 second, I can see it now. It stopped. Yes, I am happy with this CTG. Yes.
Okay, cool. I've been encouraging our midwives for the last however long I've been in this role to leave the CTG. I don't know. I personally, I'm happy with what it looks like. I'm happy that it's met. With that tiny, even though it's less than a minute of loss of contact, I would much rather keep it on for at least another 10 minutes, just so that I can I just would feel more confident sending a woman home with a little bit more trace. But that's a personal thing. And obviously, like Mr. Naguib said, we're following the Dawes-Redman rules. There's no contraindications. If it's met at 10 minutes, you can take it off. Cool.
I just have a question, like, Cara, for example, because obviously this is very important, the point that you and Mr. Naguib are raising. For example, if I'm doing Parto-Shaw, Amni-Shaw, I know they have, for example, a sensitivity of 99%. But Dawes-Redman, we don't have like percentage, and I always take it as guidance, and it never eliminates my personal like view and assessment of the CTG. So obviously, if you, Mr. Naguib, now advises that we can actually rely on it like 100%, I will follow that. But I always thought of it as a guidance and a tool for reassurance. But if I'm not happy, or I think I need more, just because I don't have sensitivity of Dawes-Redman, or do we? Maybe I've not read enough and I don't know if it does. But for example, as a test, let's say, I know, for example, Amni-Shaw, Parto-Shaw has got 99% sensitivity. But for Dawes-Redman, do we have, can we say Dawes-Redman met, so I'm happy? I mean, this is for future topics. It's really important, to be honest.
So Maya, I see your point. What I want to say is Cara's point is different. Is not that we are not happy with the CTG. She advises that even if it meets criteria, to put it slightly more in order to have more idea of the CTG. What I'm saying is different from this. You know, like what I'm saying is, yes, of course, Maya, if it is a guidance, yes. But if the Dawes-Redman tells me there is no concern, I see the CTG and the guidance is telling me no concern. Myself, I see no concern. Then I don't have to extend it for the extra 10 minutes to know more information. Of course, Maya, if you see the Dawes-Redman and you are worried, oh, this is not right, no, ignore the Dawes-Redman. You know what I mean? I'm not saying get the Dawes-Redman to be like a Bible. But at the same time, we can, if we are following the Dawes-Redman, we cannot advise routinely to extend it for 10, 15 minutes to have more idea of the CTG. You know, there is, it's not completely reliable, yes. It is not extendable to another 10, 15 minutes, but something in the middle. We made it, we depend on it if there is no other concern.
Just to back you up,
I see. Yes, that's clear. Yeah, thank you.
When you do the Dawes-Redman training, they do say that there isn't a percentage, but when they've done their research and they've looked into this, when it meets criteria, this is the reason you should take it off, because it's looking at more elements than you can by the eye. But you shouldn't depend on it solely. You should still be looking at the CTG. Does that make sense? So it's a sort of a dual approach when they teach you. So it's a bit of what you're both saying, really. You shouldn't just rely dependent on the criteria meeting, you should still eyeball the CTG, and I think that's what we should be doing anyway. Sort of a dual approach when they teach you at Dawes-Redman.
And what was it, the criteria that, you know, when Ahmed Zaima does the teaching, he says we have to wait for 60 minutes. Do you remember, Cara? What is it that we have to wait for 1 hour? What is it? I'm still like confused about that point.
Yeah, that's STV, Maya. So just to sort of add a little bit more to it. So Dawes-Redman is the only analysis that's clinically proven to help with neonatal outcomes. And that sole element of the Dawes-Redman criteria being used is a lot to do with the short-term variation, or the STV. So the one thing about STV, which I think more people need to be encouraged to remember, because a lot of people use that when it's been less than 60 minutes, for you to accurately interpret the short-term variation, the CTG monitoring needs to be on for a total of 60 minutes to get an accurate representation. So people circle it all the time after 20 minutes and people write it in their notes and whatever. But actually, for short-term variation to be complete and to be completely 100% accurate, it needs to have been on for 60 minutes. And then basically, if the STV is less than I think it's 3.5 between up to 39 weeks, what that can tell you is it's a 24.1% chance of having an IUD.
That's based off the truffle study. If you've got
that's the
baby,
truffle.
Yeah,
that's the truffle, but the truffle is still 34 weeks, isn't it? But I think so the STV in that case, we needed for 1 hour example in those cases on antenatal ward, which we, for example, are worried IUGR and not meeting criteria, and those cases then we have to leave them for 60 minutes. Is that what it is? For example, in this case in triage, we should be happy with the 20 minutes when it meets the criteria or until it meets the criteria. But now what I understand from this is for we had few antenatal HOPE recently, HOPE CTG. So I need to keep those for 60 minutes for me to be 100% happy, isn't it?
Yeah, unless it meets before. Because if the criteria meets before 60 minutes, you can be reassured that that's the STV is normal.
Okay.
But if it's not meeting criteria,
I'll leave it for 60 minutes.
Yeah.
Okay, cool. Thanks.
Okay, perfect. I just want to just go back a slide quickly. Yeah. So this was at 36 plus 5. So this was her second admission. She came in with abdominal pain. She reported constant pain in her abdomen, no scar tenderness. Investigations were normal. Blood pressure and urine were all normal. OS was closed, so she was speculummed by the SHO. And so she was sent home on this admission. Dawes-Redman criteria again met at 27 minutes. Another thing just to do with Dawes-Redman is when we've got women that come in for abdominal pain, depending on sort of what type of abdominal pain that they're having, Dawes-Redman actually is again sort of an inaccurate thing to use, specifically with contractions, because this Dawes-Redman is an antenatal CTG tool. So if you have any suspicion that a woman may be in labour or latent phase or anything like that, then it shouldn't be used. There looks like on this CTG that you can see a little bit of uterine activity. It could just be maternal movement and whatnot. There was nothing that was documented about any contractions or any pain being palpable. And obviously, like it says in our triage note, all the investigations were completely normal. So this lady was sent home. Okay. So she comes in on the 17th of the month. I didn't write down what her gestation was. This was a couple of days later, so I think she was 37. She was 37 weeks and 1 day, I believe. This is her that she came into triage and her CTG was started. She was contracting. Blood pressure is 130/88, pulse of 124, resps of 19 and sats of 100. She was immediately put on the CTG and she was examined by the night team at 7:45 in the morning and found to be 2 centimetres dilated. This CTG continues for a little bit longer. So as you can see, our baseline still remains sort of stable at around 140. We've got some good variability in this one, possible acceleration there as well. Not really sure what's going on with the TOCO at this point, but I think it will start to become a little bit more clear. Dawes-Redman was put on inappropriately, which wasn't documented. But at this point, it's now 8:33 in the morning. It's been escalated to labour ward that this lady was booked for an elective caesarean section but unfortunately they couldn't accept her at this specific time. And it actually took another 40 minutes of her waiting in triage to be transferred over to labour ward. CTG was stopped at sort of 36 minutes, at 60 minutes. Any questions or queries so far?
Did she have any resting?
She came in with tightenings, or what did she come in with?
So she came in with tightenings. Yeah, she came in with contractions.
Okay. So she came in with contractions. Thank you.
Saoirse, did you have a question?
Yeah, did they check for resting time?
No.
Okay, thank you.
Okay. So she remains in triage. This is your CTG.
What's maternal pulse?
120. That was when it was done at 7:40 in the morning. It's not repeated. So this is an hour later.
Was triage busy?
Triage, no.
Okay.
Labour ward was.
And did they didn't take the pulse again at the end there?
Yeah.
Okay.
No. So she was given some Entonox in triage because she was in agony at this point.
Any PV loss at all?
No.
Any signs of fetal movements?
No.
Any doctor review?
No.
Okay. What are you thinking?
Tell me. I know what happens. You tell me what you think.
There's a change in baseline here, isn't there?
What does this CTG tell you? What does it say to you?
So our baseline before was 140, wasn't it? And at the start, the first 20 minutes here, I can't really interpret that, whether it's decelerations, accelerations, loss of contact. You don't really know what's going on for the first 20 minutes. Towards the next 20 minutes, towards the end, you've got a change in baseline. The baseline looks like it's 105, 110. I don't know if that's sharp tooth or sort of sinusoidal pattern. Just go back to the previous one. The variability I'm just looking at. And again, previous one. Okay. I don't know if I'm just looking at it too long. Potentially the variability slightly changed, but your baseline's changed.
Yeah.
Some research has shown that your baseline can change if you're coming sort of into second stage. But in this, she's what, 1 to 2 centimeters. Her last delivery of an SVD was what, over 10 years ago.
Yeah.
Sort of
and a section in 2008.
So you're treating her as a VBAC here, and she's had previous admissions for sort of abdominal pain.
But also bear this in mind. Her last cesarean section was at 24 weeks.
Yeah, I'm thinking this section definitely we need more notes. Was it a classical C-section? Because this is what I'm thinking as well.
That's a very good
section. Exactly.
That is an amazing question,
and
Maya.
I think, yeah, because obviously 24 weeker, you need to get this baby out. Obviously there is a reason why somebody decided that she's going to have a elective C-section after her having previous 3 vaginal births. So it must have been, I'm just deducing that it must have been classical C-section. Otherwise, they might have wanted to put a balloon or something. She is a good candidate for VBAC if it wasn't, kind of like a classical C-section.
So
I'm just deducing by not looking at the notes that it must have been a classical C-section. Otherwise, why was she not offered a VBAC in someone who had a previous 3 vaginal births?
So the answer to this, Maya, is there is 2 aspects to that. So I have done maybe 40, 50, 24 weekers, and in many places, like in many hospitals, and in none of them I have done a classical section. I always did a normal C-section, and in the worst case scenario, I did an inverted T or a J shape. So this is, like we cannot assume it is a classical C-section. The second point is this lady didn't speak English, and we were using interpreter all the time. And she is the worst historian ever that you can ever see. Up to that she saw about 5 doctors with interpreters really. And the 5 doctors said different gestation of delivery. One said 24, one said 28, one said 32, and one said 34. And the reason in the discrepancy is that the woman was saying in some occasion, I delivered at 6 months, and in some occasions she said, I delivered at 7 months. She didn't say it in weeks, because in her country, they don't use weeks. So from that, the doctors who saw her in the clinic did not say it was a classical. They did not assume it is classical. And we cannot assume it is classical until proved otherwise. And so I slightly disagree with the fact that we must deduct from that she is classical. And it is
but then why did someone? I'm sorry.
Yeah.
Why did someone counsel her regarding 28-week section? What was the rationale? I mean, we're missing a little bit of information with the counseling clinic. What if the discrepancy? What's the indication of sectioning her? So far from what you've mentioned, her history is GDM. Am I correct? And her history is smoker, Paris woman, para 4, and 1 C-section at 24 weeks for prom. So what would anyone want? Why would anyone want to section her at 28 weeks or 34 weeks?
Because the counseling which was in the notes said that after giving her the options, she wanted a C-section.
No, I mean the gestation. You said there's discrepancy and people deciding. So somebody said we'll give you section at 28 weeks, and somebody said we're giving you section at 34 weeks. Why? What's the indication?
No, Maya, you got it wrong. Over there. What Mr. Naguib is trying to say is that it's regarding the previous gestation where she had the cesarean section. There was a discrepancy regarding that gestational age, not during this pregnancy.
I see. Okay. Perfect. Thank you.
And that's why she was given the option. She said, I want a C-section, and because she's GDM on metformin or whatever, she was given a section date at 39 weeks.
Okay, fair enough. Yeah, thank you.
But again, still raise a fantastic point. Obviously, like Mr. Naguib said, the communication issues that were present in this case were clearly big ones. But yeah, considering like I was going to mention that before Mr. Naguib kindly filled in all the extra details. But yeah, there was discrepancy as to whether it was 24, 28 or 32 that she was in her previous pregnancy. However, it wasn't deduced whether or not she had a classical or a normal cesarean section wound for this pregnancy. For the previous pregnancy, as to how that would maybe change our interpretation of what's going to happen in this one.
Yeah, and by the way, we tried, or the doctors who saw her tried many times with her to get any details from her country. She was not cooperating. And also, as I said, if I am even, I haven't seen this lady, but I am saying, if I put myself in the shoes of the doctor, seeing her, I wouldn't 100% in my sane mind say that, oh yeah, she was a classical, because in many people who come from the Eastern Europe and they say to me 6-7 months, every 6 months, as we know, is 26 weeks, even not 24. So and I am sure my colleague registrars and 100% that we do classical in this country. So as I said, I have done so many, but still I haven't done in one of them classical. Even the one I did for the IUD 20 weeks recently, I did a normal cut on the uterus. So I mean, it was harsh. It was very, very harsh, and we debated and we declined accepting the finding from HSIB that this should have been a given, that she had a C-section. This is not right. This is a decision in retrospect, and a finding in retrospect which is unfair on the doctors who saw her in the clinic.
Mr. Naguib, I don't know this case or anything regarding this case. However, if we don't have definitive information, I mean, obviously she has delivered in a different country, so you have to assume the worst, isn't it? So if I'm faced with this case in clinic, now this is different to the management of the CTG, obviously, but I have to assume the worst and act upon it. So if I don't know which gestation, if she tells me probably I deliver 24 weeks, I have to assume the worst and act on the worst, given that I don't know what she's had. I don't think imaging can help us in this situation. I don't think imaging, like on scan, if you can see on scan that she's got a transverse, I don't know if technology can allow us to see if it was a classical or it was what sort of scar with MRI. I mean, I don't know. I mean, obviously, I need to ask a radiologist to see. But if given the ambiguity of the information given to me, I have to assume it was a classical C-section at 24 weeks done in another country.
Okay, let's take this back and say, okay, she's seeing Naguib, for example, and I am assuming, or let's say she's seeing Maya, and we are, me and you, assuming it is a classical section. Let's put it like this. What gestation do you like to deliver her?
No, still the same. So this is the management would not differ. But I don't have any base. It wouldn't differ at all. And she's going for a section. I would still recommend. I've seen this lady in my clinic. First time I've seen her, para 3. The last delivery was 24 weeks in a different country. Poor communicator. I will say, I'm booking you for elective section, and I'm assuming that you are a classical C-section, because she's not delivered in my country, and I don't know what sort of expertise in which country you've delivered in. I don't know exactly what we couldn't get notes. We tried everything we can. So I think you have to base everything on an assumption of a worst case scenario.
Fantastic. Okay, so now we are going.
We are going down. Is not going to change. I'm only assuming she's been booked for C-section, given that we have no clear evidence of what sort of gestation she had and what sort of surgery she had. But the management is not going to change. 39-week section is a very just plan.
I will go down your thinking, and I will say, if it is me, and I am 100% knowing that somebody had a classical section, I would say that I would deliver at 37 to 38. I would do it 1 week earlier. This is me. But but again, if I am saying this to myself and I am putting my shoes of a risk manager who likes to do the things in prospect, not retrospect, not knowing because of course I know the case, but what I'm saying here, I am saying I'm putting myself in the shoes of the doctors in the clinic. Would I have changed the management? I would say no. Maybe I would have said section at 37 to 38 weeks. But what if this CTG in front of me has happened at not 38, 36. So, because let's be honest about it. Classical section, we have cut the upper segment of the uterus, and I cannot guarantee this uterus will not give way at any point. So, whenever she comes, so I will have to open her up quickly. But at the same time, if I am managing her CTG wise, and I'm seeing this CTG in front of me that we are all perplexed about it, I would say, in not in this specific one in front of me now, but the one after that Kara showed and Sorsha was asking, I would treat it as a cat one, irrespective. It is classical, because remember, Maya, as well, how many sections we do which are not classical, that there was extension, and the extension go up and down. Will we all treat them as if they are classical? So the decision by the investigators outside the hospital, who decided that we were supposed to think about classical, I personally think is harsh, and we cannot assume that everybody who had a again, she said 6 months. It wasn't 6 months, it's 26 to 27 weeks. So no, we can't say that it was 24.
Sorry, just to put a few points over here. Well, Maya, yeah, I absolutely agree with you. Like, if it is a classical cesarean section, then definitely we should be more cautious about it. But when I think about the case, if we remember, she was sectioned at 24 weeks, and the indication being PPROM with arm presentation. Now, with arm presentation, I would more think about an inverted T rather than a classical C-section. And if I assume that this lady had a classical C-section, my management plan will only change in offering her a C-section maybe between 37 to 38 weeks, and nothing else than that. And my only worry will be that if she goes into labor, her chances of rupture is a bit high. How much high? The chances of rupture in a classical C-section is around 5%. So that means 95% of ladies who had a classical C-section previously will not rupture even they go into labor. Now, if we study this lady, my only concern is up to this point, I'm happy with the CTG. And if you look at Dawes-Redman says that it only looks at fetal hypoxia, but it doesn't look at any acute feto-maternal cause. So in this case, if I'm suspecting rupture, the previous Dawes-Redman and 32 weeks will not give me any suspicious attitude. So I'm happy with the CTG till now. Now, if I look at the next segment, Kara, can we move into the next segment, please? Yes. Now, this is the segment where it is giving me serious doubts. If you look at the side from the beginning, a baby who was absolutely happy previous to this trace, what is the unsettling event which has made this baby unhappy? Remember, she's a previous C-section and she's now 2 centimeters. So the thing which is going on in my mind is the scar giving away at this point, and is the baby struggling to scope? So if I am a registrar present on the triage at that point, I will hit the emergency buzzer at the beginning of this trace. I will like to come to bring all my team in and provide her to a category 1 section. Because if you see, she gave us almost 20 minutes, 20 to 25 minutes at this point. And if I see at the borderline of a category 1 C-section, the rule of 3, 6, 9, 12, the baby should be out by 12 minutes. So if I start from here, the baby should have been out by 8:42 if I hit the emergency buzzer at the beginning point. By that point, if I look, the CTG, the baby stress is still coming back to the baseline. Variability is still maintained, so the baby is still maintaining. But at this point, after 25 minutes, first of all, I'm not sure whether I'm monitoring the baby or the maternal pulse over here. That's first thing which we need to confirm by bringing an ultrasound. And if it is the baby, this baby has now dropped the fetal heartbeat quite severely. I'm not sure whether this is the baby's heartbeat, because for me, if it's a rupture, this is a permanent cause of fetal-maternal hemorrhage. And in this case, the variability should not be present. The baby is not trying to compensate. The brain damage has already been done. So for me, hitting the emergency buzzer at the beginning, delivering the baby at 12 minutes, and if I'm having this trace, then I will put a scan over her and first make sure why this baby has dropped the fetal heartbeat. Is it the baby's heartbeat at all, or am I measuring the maternal pulse? That's my 2 cents for this case.
Completely agree. Completely agree. I think like by definitely when we see it kind of dropping, this is where the emergency buzzer should have been relevant, and then she should be shipped in theatre, and I think the scan in theatre. The other thing we have to highlight is that there was uterine irritability from the previous segment, Cara. So there was definitely uterine irritability. And number 2, maternal pulse is 124. And this is not, to me, a choreo trace. So those 2 elements should highlight to us that something not right is happening. The mom is trying also to compensate, and there is uterine irritability. So those 2 elements should be always taken into consideration. I'm assuming the TOCO is picking up, and she's not a high BMI lady. So I completely agree with Neil. From the first time when we see those decelerations that trying to recover, and there is 2 minutes baseline, we can see at around 8:47. So this is the baby trying to go back to baseline. I think this is enough evidence that there's something, as Neil said, that there's a dramatic event that happened with the maternal pulse, with the uterine irritability, to assume that we've got a little bit of a scar problem here.
Thank you, everybody, for fab contributions. That was great. I will move on. So this CTG finished at around 9:10 in the morning and then was restarted at 9:20. The consultant at this point comes in and does a ward round, and the plan is made for a category 3 emergency cesarean section. At 09:50 pre-meds are given. And then she's moved round to theatre between the end of this trace and the start of another.
Has anyone palpated the uterus to see what's happening?
They haven't.
Okay. Would we?
Yeah. 100%. But also what concerns me as well is the fact that, first of all, Mum's observations were taken at 7:30 in the morning. They haven't yet been taken by a member of staff on the day shift, or if they have, they haven't been recorded, so I could be wrong here. But if you've got Mum's maternal pulse of 124, what shocks me is the fact that we put fluids up for absolutely everything to try and fix the CTG, and yet they haven't even been put up here. So I don't even know if that was sort of recognised as being a problem, because nothing was really done about it. Also, they didn't take her temperature at that point either. So if you've got a mum that's tachycardic at 124, ideally what you do is you check the temperature as well, just to sort of see if, okay, this is an infection, then not that I think this is an infection in the trace, but you know what I mean? You'd take a temperature, you'd look at it and go, okay, maternal tachycardia, let's double check what her temperature is. Everybody starts fluids for everything, but for some reason in this case that wasn't done. Also, this last CTG it wasn't escalated as being a major issue, and I'm surprised that this wasn't put through slightly more urgently, considering the previous trace. Whether or not they were looked at, I am unaware. But yeah.
I'm just thinking, when they brought her to labour ward here and recommenced the CTG trace, they would have had to palpate to put her on the CTG trace. So they would have palpated, they would have felt sort of skin if she felt hot. Usually that's quite a good indicator, isn't it, sometimes? And actually, if she felt abdominal pain, or as you're palpating, oh, that's tender, etc. So because that hasn't been raised, were we falsely reassured with that, potentially?
You know what though, Saoirse, you say that, but how many times have you walked into a room and someone has gone, where did they put the monitor on last time in triage, or if there's like a slight mark on the skin where we've clearly had a monitor on. I mean, this CTG was on for over an hour. You know, when you've got women on the CTG for an hour, there's normally like a little indentation in the skin, so you can pretty much look at a woman's abdomen and see where the fetal heart rate is going to be picked up sometimes. I'm not saying that was the case at all whatsoever. Yes. However, no abdominal palpation's been recorded on Cerner at all, and it's not documented anywhere. So this is purely by assumption, but I don't think that this woman's abdomen was palpated.
Okay, thank you.
Fine, we'll go. This is her theatre CTG. So she entered at 10:10. Anaesthetic started at 10:21. Knife to skin was at 10:51, and delivery was at 11.
Looks like an unstable baseline, doesn't it? Sort of that slow coming down the baseline. Started at 160 and now we're going lower and lower.
So we've gone from 140 to 105 to 150, 160, and now back down to almost 120 again. I just think this baby's telling us that they are very, very unstable at this point.
I agree. I think now the brain is definitely damaged, but the heart is still keeping on. This is a typical sign of how when you do get like a brain instability and then you start having, this is the wandering baseline we talk about. The heart is still functioning, obviously, but this baby's brain is injured.
Yeah. Okay. Would anybody, this obviously delivery happens at 11. Would anybody like to guess anything like APGARs or gases for this baby?
Gases will be around 7, between 6.9 to 7.05, I will say.
Yeah.
APGARs will be, I will say, like I want to say 005, but.
Did you just say 005?
Yes, I want to
say
I
think the APGARs would be worse than the gases, definitely.
Yeah, I think the gases would be
bad APGARs, gases better. Yeah.
Okay, so I'll go to the next slide. I'm just preparing. This is a quite sensitive case. When the abdomen was opened after knife to skin, the placenta was visible, and this was a confirmed uterine rupture. The baby was found in the abdominal cavity. So Neil, you were completely spot on. APGARs were 005, arterial gas of less than 6.75, lactate of 20, HB low 153. I think the lactate on the venous was unrecordable and the base excess was unrecordable as well. But yeah, I think we all know that if cord gases are less than 6.75, this has a very high incidence of non-compatibility with life. Her estimated blood loss ended up being 1.7 litres. This baby had very extensive resuscitation, which was HIE identified as grade 2 and was transferred to St George's for cooling. The gas did improve very quickly after delivery, up to about 7.0, but sadly after 9 days, the decision was made to withdraw care just due to significant issues with baby, and baby passed away, unfortunately.
Did we get the placenta by any chance? Was placenta come back as anything?
I'll have I don't have my card on me. It was.
Why are you interested in the placenta, Sosha, out of curiosity? Why would you want the placenta?
Honestly, to just see if there was anything beforehand. She had multiple times where she came in with abdominal pain, and potentially, I know we've got a uterine rupture here, and that's the acute event that occurred. But just for sort of my own learning benefit as well, was there anything long-standing prior to this that, I don't know, the placenta may have shown? Just my interest, if anything. Because the CTG is showing this, it's interesting to know, was this potentially, we were picking on, when did we pick this up? When we're sort of, she remained in triage? Do you reckon it occurred, or do you reckon this was a long-standing rupture? That's what I was more so thinking about. Was it a sort of partial rupture? And then,
so like clots, you're thinking of more like abruption before the rupture?
Yeah, I don't know if there was maybe something that happened or occurred. I don't know.
So I'm also assuming this placenta, by deduction, must have been anterior placenta, and then maybe would the baby been saved if it was a posterior placenta? I'm not sure.
Just one question to Mr. Naguib. Mr. Naguib, when do you think this rupture happened? Because to me, if Kara, you can go back to the slide of CTGs.
Which one, Neil?
Yeah, before, like this triage one. For me, I will think the rupture has happened at this point, the junction between the 120 baseline and the 140, and the rest of the entire trace, we continued to monitor the maternal heart rate. Am I correct in thinking that?
I agree with you, Neil, and I want to add something as I was also involved in her risk review before it goes to HSIP. This lady was in pain for 2 previous days prior to coming to hospital. And she was using antispasmodics that she had from her country. And she didn't tell anybody till after delivery. So also this masked little bit the effect of her like contractions or whatever she was. So, but to answer your question, I agree with you. The junction here, that's why I was thinking this is the time, or this what I put in my report even before it went to HSIB, that this is the point of needing to be delivered immediately.
Because to me, the trace previous to this junction point and the trace after this junction point just looks two different babies. Am I correct in saying that?
Yeah, you are right. Yeah, you are right. Yeah.
Perfect. Just to add very quickly, the placenta wasn't sent for histology, but the post-mortem, I don't think we've had the report yet. We've not received the final report yet.
Kara, just a quick question. Did we check the maternal pulse at any point of time after that 124?
No, not at all, Gargi.
In the theatre, did we check the maternal pulse? Any
I think it went on, obviously, when she entered theatre, but that's not recorded anywhere on Cerner, but she was still incredibly tachycardic at this point. So for all we know, that could have actually been baby being picked up on the CTG.
Yeah, because if we consider the point where the fetal heart was 100, that was the point of uterine rupture, and we delivered the baby at 11, I would assume the baby would have died by that time.
Yeah.
It's more than an hour. The baby won't be able to survive that long.
But again, it depends on the amount of placental detachment. That's how the baby is getting the supply. Maybe the placenta was not detached at a single point, and that's why the baby got deprived of the blood supply slowly and slowly. That's what kept the heart going, but the brain was much more sensitive, and that's why it perished.
I think it's interesting to know it was only HIE grade 2 as well after the MRI. So that's quite interesting that they didn't think it was a severe brain injury. They did just think it was a grade 2. So that you could be right that it was sort of a partial eruption at the same time. And where we sort of ruptured it, that's why potentially it would be interesting to note with the placenta. But yeah.
I'm very much interested in when she got reviewed, obviously, and then the decision was to wait and then to do a category 3. What did they comment on the CTG, and what were they like? What was the thinking? I know they were not happy, but what was the because we do have baseline drop and so did they kind of comment on what they were the rationale of delay or what they were thinking?
Not really. I mean, but the thing is, Maya, if you looked at this one just on its own, for example, the consultant ward round was at the very beginning of the CTG. I mean, I know that the unit was very, very busy on this particular day, but in terms of ward run, I don't know whether or not the previous CTGs had actually been looked at on ward round. But it's just, again, just to stress the importance of that to anybody that's on the call. You know, I went on to Hope Ward the other day and was asked to do a fresh eyes review. And my first question was, what was the previous baseline? And I discovered a 30 beats per minute increase in baseline that wouldn't have been identified had we not looked back on the previous CTG. So it's little things like that that I don't know if were missed. But if you were to look at this just on its own, for example, then I don't know, would you, like the first sort of 10 minutes of CTG, how long does a ward round last? You'd probably think, okay, yeah, we do need to give this woman pre-meds, we need to get her ready for theatre, but we're not in any specific rush at this exact point.
Well,
but to be fairly honest, like, oh, sorry, go ahead, Neil. Go ahead.
No. Actually, Kara, I absolutely agree with you because when I am a registrar, I'm in a labor ward and I'm seeing a lady, I'm seeing the CTG which is happening at that moment. If the previous CTG has not been escalated, then rarely we look back into the previous CTG, isn't it? And if I'm looking at this phase, if no history, no previous CTG, I will comment this as a normal CTG. But the question is, the $1 million question at this point is whether this is the baby's heart or not. Maybe the baby's heart is lying way below at around 100, 110, or maybe between 90 to 100 with a very low variability. That's what I'm trying to answer. Because if this is the baby's heart, then somehow the survival of the baby with a HIE grade 2 is somehow quite difficult to explain. What I will rather think, this was never the baby's heart at all. The baby's heart was lying somewhere down, which we never monitored.
May I say what, like, I know this might sound crazy, but you know, so we are trying to pick up pieces of the puzzle. The three most important things that I would have wanted to pick on in this case is number one, maternal tachycardia when she came to triage. Number two, we have two reasons why a woman would have uterine irritability. Number one, abruption or like a scar rupture. Number two is infection. In this case, it's a little bit kind of like too obvious that this is not infection we're talking about.
Yeah.
So when you look at the uterine irritability, I have to presume this is either abruption or scar dehiscence. So in this case, given the history and the uncertainty of what we had, I know this will sound crazy, but if I don't want to take her for Cat 1 section, I would have taken her to theatre and ARM'd her. Then you would see the blood flooding, and then I would Cat section her at that same moment. That is enough confirmation to tell me, to confirm my doubts. If I'm thinking this is, I don't know where the baby's baseline, the LICOR is 100% clear, and the baby did not start decompensating when I aired her. Remember, she's multiple and she's 2 centimeter. And if I'm doing it in theater, I'm covering my back. If all is clear, I can put a clip and then I can have the luxury of waiting. So this is option 2. I know it sounds crazy, but like, given those three pieces, so I can be only thinking of two things in this scenario as a registrar looking after her: uterine irritability, maternal pulse. Given the history, I'll take her to theatre because I'm not happy. ARM her, flooding blood Cat 1, not flooding blood. I will just put a clip. Mr. Naguib, am I too crazy with that? Or Mr. Naguib is getting hand over now, probably. Okay. So,
But Maya,
Neil, do you agree? I don't know.
Maya, like, yeah, I do somehow. But the question is, if I'm looking at this trace, like, remember the previous triage CTG was never escalated. So I don't know. Something happened previously. To me, at this point, there are two factors which you are saying is a maternal pulse rate, which can be due to pain which can be due to anxiety. And yes, uterine irritability is there, but Maya, tell me frankly, with a normal CTG, with the presence of uterine irritability, do we ARM all the ladies at theatre? I know for this lady,
No.
because
But this one, I'm thinking, definitely we don't, because it's going to aggravate your uterine instability. You are going to make
absolutely,
it much worse.
a-
And this is why I'm
absolutely,
saying, when I see a bad trace, I never ARM. Never. You don't want to stress the baby out. However,
but
I'm saying it because you are in doubt and you don't know what's going on and you don't know exactly what you're dealing with. I mean, in this case, I would have sectioned her the second I've seen it. But as you said, it wasn't escalated. You never ARM.
yeah,
This is actually against the rule. This is why I'm saying you will think
absolutely.
I'm crazy. But then if you're thinking, I don't know what I'm dealing with, when you ARM and you see this is 100% confirmation, if you don't want to open her up.
But at this point, looking at this CTG, because as we all say, CTGs are like snapshots, like which tells us at this moment how the baby is behaving. And if I don't know the previous CTG, which was concerning, of course, I agree. At this moment, if anybody looks at the CTG, look at the 140 baseline, good accelerations, good variability. Yeah, at the end of the part, 5 minutes, yes, it's debatable. But other than that, like, I don't find this CTG very concerning. But the $1 million question is whether this is the CTG for the baby or am I monitoring the maternal heart? That we
Yeah,
never
but then we
confirm.
had the confirmation from the previous one. So I'm not worried about this one. This one actually would have
No,
kind of messed the situation
no,
worse.
no,
I would have acted on the one before. So the
no,
one
I'm telling you.
before is the one I would have acted on,
Yeah,
not this one.
absolutely. Absolutely. Agreed on that. But I'm saying, as a labor ward registrar, if suppose this scenario happens again, the previous CTG has not been escalated from triage. Lady comes to labor ward, you and me, we are the labor ward registrars. We go and see the lady in the room. We see the CTG with a pulse rate of 124. We don't know about the previous event, previous CTG. Will you be too much concerned, being honest,
You
with
you
this
would you
CTG?
would you said you would scan her to see if this is fetal pulse, right?
Yes,
So
but
your
only
approach
if
was
I
to go and
know.
scan her,
But
but
yeah, but
but
only if I
the
know
least
about the
I would do
previous
is put a
CTG.
clip on. If I'm
Yeah,
concerned, I'm not picking the
yeah,
maternal
agree.
slash. I want the
Absolutely,
fetal
agreed.
heart. So either
Absolutely.
scan her. This is one option which you went for. The second
Oh.
option is obviously if I know I'm very busy, both theaters are full. I mean, on acting on the first one, I would have taken her probably 20 minutes before that. If I'm
Mm.
still not sure I'm picking maternal pulse, I'll literally air on her and put a clip.
Yes, Maya, I completely agreed with that. But the question which I'm asking is, this is something which I will agree if I know that the previous CTG in triage has been concerning. Now I'm having doubts. But suppose as the XYZ registrar and the ABC consultant who was present on the day, now that person doesn't know the previous CTG because the previous CTG was never escalated to them. So what they are looking at this point is they are thinking this is the baby's trace and the baby is absolutely fine. And that's why if you look, it's not even a category 2, it's a category 3 cesarean section because they are thinking the baby is absolutely fine. This baby just needs
Sorry,
delivery.
I need to differ. If we having a maternal pulse of 124 and this is the trace, I would at least feel the abdomen of the patient to see if there is any scar tenderness or anything. She had a previous VBAC at 24 weeks and a pulse rate of 124. That will bring my suspicion of a scar tenderness at the very beginning. That's something the clinical examination during the ward round could have picked up something which may have helped us. That's what my understanding is.
Just to go on that though, how many times do we do ward round? I've done plenty where no one touches the patient, and I think that's something that where we do go wrong. So I think sometimes that is the case where everyone just stands at the end of the beds and just looks at the patient or looks at the woman, and this is where we look at the CTG and everything's fine. And I think that's where one of these issues is. So that's that human factors. It's 9:30 in the morning, everyone's just handed over, and you also have that element of human factors, we've got a busy labour ward, things are happening, the CTG's on, we've got a fetal heart, we're just assuming more so. So that's something we could take from this, is actually touch the patient and, like you said, see if there is any tenderness. We mentioned that about the abdominal palpation as well.
Definitely. And also documenting in the notes, like if there is any scar tenderness or if there is not any scar tenderness, that would have saved our back. Because if we are assuming this is a fetal heart, it doesn't come up with the outcome. So I think we are picking up the maternal pulse most at some point over here. So.
But also, like, maybe I'm not the most experienced in scanning. I don't know, because obviously I've never seen anything like this before. If scanning would have actually detected more, given us more information and worry. So Neil's point was I would have scanned her, because obviously when you scan, you do see, for example, the placenta, you do see the wall. That might have also been a little bit helpful if we, as Gage said, examined her and then completed like a thorough examination, because obviously it wasn't a normal presentation. I don't know how you can see like there's blood in the abdomen, the baby's in the abdomen. That could have given away. I don't know. Maybe we need to ask a fetal medicine consultant what they can see if they scanned her on that case.
Kara, just out
Yeah.
of curiosity, like in our standard operating protocols we have for triage, is it anywhere mentioned that if there is an acute resetting of the fetal heart rate, then a doctor review is needed, or a registrar at least needs to review a patient?
Do you know what, Neil? I think what happened was that obviously around this time, I don't know whether it was sort of brought up that this was abnormal. I don't know whether it was recognised that this is a pathological CTG, and therefore it was escalated, but I don't think it was escalated with any like haste. So it was a case of, okay, yeah, the CTG is abnormal, let's bring her to labour ward, but there was no sort of like rush put on it, and I think that would have also caused a delay. I think from everything that you guys have been saying, I totally agree. This case was incredibly mismanaged, and there would have been a few very simple things and very simple tasks that could have been done to help avoid this and prevent it being sort of this severe. In terms of a stop, Neil, there isn't one, but then if you don't recognise that a CTG is pathological, then you wouldn't feel the need to escalate that quickly to an obstetrician. You just say, this is a problem, the CTG is suspicious, we need to move you to labour ward, but there was no haste about it.
Do you think they're using the labour ward terminology, saying suspicious rather than abnormal?
Yeah, probably.
That's where we're wrong. We're assuming it's sort of labour, but we're not.
Yeah, I mean, I make posters pretty much on a weekly basis, and they're everywhere. And I have noticed that there's been some improvement in a lot of things. So like cord gases, when I first started in this role, I think we had like a 25% of cases that had cord gases, that needed cord gases, actually had them. And that's definitely improved. There are things that are improving, but there's only so many posters I can make. It's all about the education, which is why I present these cases on here, so that we can look at them and learn together, and they're all uploaded to YouTube as well, so they're always encouraged for people to attend to.
And one more point, Kara.
Yeah,
just one more point. If you look at this
one more, Neil, because I'm hungry now.
Yes, me too, my dinner is getting cold. Because the only time we measured her pulse rate was in triage, am I correct?
You are correct, yeah.
And that was 124, which somehow matches exactly with the fetal heart trace, which we got after the event.
After the what?
No, if you go back to the
after the event.
After the event,
this one,
the heart rate has come and lying into the region between 120 to 130. And we got the maternal heart rate at 124.
Yeah.
Which is very close resemblance to the heart rate in the later segment of this trace.
Yeah.
That's why I said, Neil, that's why I said I want to know the heart. And I thought this is what you meant by I would either scan her, and I said I would put a clip, because they're the same. So I don't know who I'm catching. So this is why this is not reassuring. This is it could be maternal pulse we're picking up. So that's why I said I want to know. You said we'll put a scan, and you can obviously calculate the heartbeats one by one. Or the worst case scenario, take her to theatre, put a clip, end of story, and then
but this
you
also
would get extra.
This could have been avoided had we palpated maternal pulse, because it's very easy when you can hear a CTG going doof, 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 doof. So if you're feeling maternal pulse and it's the exact same rate, then you, like an FSC, yeah, fantastic. But by doing something as simple as taking a maternal pulse, which is pretty much the first skill you learn as a midwife, and I'm sure it's one of the first things that medical students learn when they do their first skills lab, is how to take a set of observations. We've gone from, our technology is fantastic, but we've forgotten all of those initial skills that you learn. And actually, we didn't need an FSE in this situation. This contact is quite good. If we'd have done a maternal pulse and palpated it and listened to the fetal heart rate against maternal pulse, that could have been almost ruled out, but that wasn't done in the first place.
Thank you, Cara. Was it a classical section when they opened her up? What was
it was, yeah. She had a classical previous cesarean section.
Okay, thank you.
I think the key points to sort of come across from this is, let's not forget the initial skills that we learn when we first start in medical school, or we first start as midwives. Escalation is key, and if you've ever got any concerns, please do raise them, and raise them quickly. And I'll continue to do my best to raise awareness for when these sorts of cases are very, very abnormal and aren't escalated in the right way. But yeah, also obviously making sure that we're using language line at every opportunity, which there was absolutely done in this situation. But clearly there was an error of communication. Could we have done something a bit more to define, to sort of figure out a little bit more about this woman's history? Is there a way we could have done this visually as opposed to just using a language line interpreter, that may have helped the situation? So clear communication is just one of the key messages to take away from it. But guys, this has been the best. I feel very happy after this case, because the contribution has been amazing, and I'm sure we've all learned something from each other here, which is the whole purpose of me doing these reviews. So thank you everyone for contributing and participating.
Thank you, guys.
Yeah.
Thank you, Cara. Thank you, Neil.
Thank
Thank you,
you.
Dagi. Thank you, Sosha. Thank you, Beatrice. Bye.
Thank you.